Assalamu alaikum. Hello everyone. This is Dr. Hesham Wageh. This is the second session of doing past test online 2020. Today we are going to do a very important topic for paper 2. It is orthopedic and specifically fractures and dislocation. I hope you have enjoyed the previous lecture. It has been uploaded on the official YouTube channel. And now I'm going to clarify some points regarding fractures and dislocations from Hesham notes. Please try to take your own notes to revise it while saying the lecture again. Now I'm going to share some pictures. This is the first one. Fractures of C1 and C2 vertebrae. C1 is atlas, C2 is axis. Fracture of C1 is called Jefferson fracture. Fracture of C1 vertebrae is called Jefferson fracture. And here, this is like that. Fracture of C2 is called hangman fracture. Okay, hangman fracture is bilateral fracture of pars intra-reticularis of axis. Some sort, it's called the traumatic spondylolisthesis of the axis. There is an important fracture also here in the cervical spine, like Clay-Chappell fracture. Clay-Chappell fracture is a staple fracture through the spinous process of the vertebrae, and it's seen classically at the level of C6 and C7. C7 is the longest spinous process of the whole cervical vertebrae, which is called vertebral prominence. So, to revise with you again, C1 atlas fracture is called Jefferson. C2 axis fracture is called hangman, and Clay-Chappell fracture is fracture at the level of C6 or C7. These are the three important fractures of the cervical vertebrae. Another one, this is an important question asked, the difference between Binet fracture and Ronaldo fracture. Okay, both of them are fractured at the base of the first metacarpal bone, while Binet fracture is a simple radial fracture, but Ronaldo fracture is a comminuted intra-articular fracture. Both of them are intra-articular, while Binet is simple oblique, but Ronaldo is comminuted fracture. Okay, both of them are fractured at the base of the first metacarpal bone, and both of them are intra-articular. You should differentiate between Binet and Ronaldo fracture. Another one, this fracture is also important, which is called Kienbock fracture. Kienbock fracture is fracture with avascular necrosis of the leonate. Remember that Kienbock fracture is fracture with avascular necrosis to the leonate. And this is also important and question asked. Another one, this is foot, and this is fracture at the base of the fifth metatarsal. It is some sort called stress fracture or Marsh fracture or Junsu fracture. Fracture at the base of the fifth metatarsal, stress fracture, Marsh fracture, Junsu fracture. Another one, some important movements at the level of the proximal interpharyngeal and distal interpharyngeal joints. The first one, where there is a slight flexion in the distal interpharyngeal joint with extension of the proximal interpharyngeal joint. This is called mallet finger. This is the mallet finger. And both of Boutonniere deformity and Swanwick deformity are the reverse of each other. In Boutonniere deformity, there is flexion in the proximal interpharyngeal joint and hyperextension in the distal interpharyngeal joint. But in Swanwick deformity, there is hyperextension of the proximal interpharyngeal joint and flexion in the distal interpharyngeal joint. This is a condition which is called Osgood-Schlatter disease or runner's knee. It is an autosomal recessive condition. Also, we called it Osgood-Schlatter apophysitis due to traction on the apophysis of the tibial tubercle due to repeated microtrauma in healthy and sports people. Due to repeated microtrauma to the tibial apophysis. It is called Osgood-Schlatter apophysitis. The patient will present by tenderness over the tibial tubercle Also, pain in the knee after activity can be investigated by an X-ray which is showing some fragmentation of the epiphysis. The patient is treated with rest and cost for 1 to 2 months. I will see also give you another picture of Osgood-Schlatter disease like this. Here, as I told you, this is apophysitis and repeated microtrauma to the apophysis of the tibia, causing some fragmentation of the bone, and it is an autosomal dominant condition. Another one here, it is called the Masonov fracture. This is an important fracture to the upper 1/3 of the fibula. Like you see here in the fibula, this is a fracture in the upper 1/3 of the fibula, and disruption of the distal tibiofibular syndesmosis. This is a Masonov fracture. And this is also important in the examination station of OSCE in part B. Commonly asked question about fracture of the upper 1/3 of the fibula, which is called the Masonov fracture. Another picture. Salter-Harris classification of gross plate fracture. This is an important also question asked. Salter-Harris classification is 5 types. Type 1, I will zoom. Type 1, like this. This is a simple gross plate disruption or fracture. While type 2, we will add the metaphysis. Gross plate and metaphysis. Type 3, gross plate and epiphysis. And type 4, the 3 is the gross plate, epiphysis, and metaphysis. While type 4 is crush injury to the gross plate. The most important information here is that type 2 is the most common. This type, where there is fracture of the gross plate and the metaphysis, it is the most common by percent, about 75%. This is the most common fracture in the gross plate. And the least common is type 5, which is crush injury, and this is about 1%. Okay, management of these conditions will be type 1 and 2 are conservative, while from type 3, 4, 5, all are need surgical operation. Okay, this is an important classification of the gross plate, Salter-Harris fracture. I will repeat it again. Salter-Harris, type 1 is a gross plate fracture. Type 2 is fracture of the gross plate and the metaphysis. Type 3 is trauma to the gross plate and epiphysis. Type 4 is the whole 3. And the type 5 is crush to the gross plate. And also you have to see that there is similarity of type 1 and the type 5. And this is also a question asked. Similarity between 1 and 5, where there is a trauma or injury to the gross plate. But in type 1, it is simple. In type 5, it is a crush injury to the gross plate. The most common is type 2 by 75%, and the least common is type 5, 1%. This is an important classification, Salter-Harris classification of the gross plate. Another one, this is called Weber classification of fracture of distal fibula. Fracture of distal fibula, of lateral malleolar fracture. It is called Weber classification. From the left, type 1 is fracture below the level of the syndesmosis. Here is below the level of the syndesmosis. And Weber type B is fracture at the level of the syndesmosis. Weber type C is fracture above the level of the syndesmosis. Okay, type A and B are stable fractures, so they can be managed conservative, while type C is unstable and may be associated with disruption of the ligaments on the medial aspect of the foot and may require open reduction and internal fixation. This is a picture to tell you that fractures in children less than 12, there is some sort of torus fracture or buckling fracture, torus fracture or buckling fracture, some sort of trauma in malleable bones where there is incomplete cortical convex bulging fracture of the long bone. Incomplete cortical convex bulging fracture in the long bones, and it is in children less than 12. Okay, it's called torus fracture or buckling fracture. Like this also, this is a buccal fracture, where there is incomplete cortical fracture causing bulging of the bone due to stress or microtrauma in malleable bones of children less than 12. Another one. One of the most important questions asked, fractures of distal radius. Fractures of distal radius. The most important one is Colles fracture, where the distal fragment of the fracture is displaced dorsally and deviated to the radial aspect. So it is displaced dorsally and radially deviated and impacted, causing a deformity, what is called dinner fork deformity. This is an important question asked. Colles fracture. Colles fracture, where the segment here is displaced dorsally. Dorsally is backwards, forming the characteristic dinner fork deformity. And there is also impaction and radial deviation of the distal fragment. The reverse is Smith fracture, the same as Colles fracture, but the distal segment with volar or ventral displacement. So Colles and Smith, both of them are extra-articular, not intra-articular fracture. Extra-articular fracture, while the distal segment of Colles is displaced dorsally and the distal segment of Smith is displaced ventrally. But what about partum fracture? Partum fracture, which reached intra-articularly. This is an intra-articular fracture of the distal segment of the radius, but it has two types, which is the dorsal partum fracture and ventral partum fracture. Dorsal partum fracture, where the distal segment is displaced dorsally, and the ventral partum fracture, the distal segment is displaced ventrally. This is also an important question. You should know it and keep it along. Okay, another picture. This picture is regarding Gastello-Anderson classification, which is called also Gastello et al. Classification of open fracture. Gastello et al. Classification of open fracture, it is three types. Type 1, where is the wound is less than 1 centimeter. Type 2, wound is from 1 centimeter to 10 centimeter. Type 3 is classified into three types. Type 3A, 3B, and 3C. 3A, where there is minimal periosteal stripping with no need of soft tissue coverage, but it may be required. Type 3B, there is severe periosteal stripping and there is imminent need to soft tissue coverage. Type 3C is crushed or mingling limb, which is needed for vascular injury due to vascular trauma. So type 1, less than 1 centimeter. Type 2, from 1 centimeter to 10. Type 3A with minimal periosteal stripping and the probability of soft tissue coverage. Type 3B, significant periosteal stripping and imminent need for soft tissue coverage. Type 3C, vascular injury. This is an important also question asked, Gastello-Anderson classification of compound or open fracture. Another one, this types of fracture of neck femur and how to manage. Types of fracture of neck femur, they form the word which is called STIS, STIS. The first one is subcapital fracture and managed by total hip replacement or hemiarthroplasty. Then transcervical fracture managed as subcapital fracture. Intertrochanteric or peritrochanteric will need dynamic hip screw, DHS. And subtrochanteric will need an intramedullary nail. However, you can keep this, like if undisplaced fracture or even displaced in young age patients, you will need a cannulated screw. If displaced in old age patient, it will depend. If the patient is less than 65, so the patient will do total hip replacement because the patient is mobile and active. If more than 65 years, the patient will need hemiarthroplasty due to limited mobility. I will repeat it again. Types of fracture of neck femur are STIS, subcapital, transcervical, intertrochanteric, and subtrochanteric. Subcapital and transcervical are managed by total hip replacement, intertrochanteric by DHS, subtrochanteric by intramedullary nail. But if didn't tell you the type of the fracture and just tell you undisplaced fracture neck of femur, then I will go for cannulated screw. If displaced in young age, so I will also go for cannulated screw, internal fixation. In some questions, you can see it, no cannulated screw in choices. You can see internal fixation, okay? Then displaced on old age, depends on the age. If the age is less than 65, so the patient is mobile, I will go for total hip replacement. If the age is more than 65, so the patient with limited mobility, I'll do hemiarthroplasty. Clarified? Okay, let's see. Like this, for you to remember. Type 1 and type 2, subcapital and transcervical, will be managed by total hip replacement. Type 3, which is cervicotrochanteric or pertrochanteric or intertrochanteric, will be managed by dynamic hip screw, while the subtrochanteric will be managed by intramedullary nailing. This is what's called Garden classification of fracture neck of femur. This is also an important question asked. Garden classification of fracture neck of femur. Who is type 1, incomplete fracture. Type 2 is complete but undisplaced fracture. Type 3 is partial displacement, and the type 4 is complete displacement. Again, Garden classification of fracture neck of femur. Type 1 is incomplete fracture. Type 2, complete non-displaced fracture. Type 3, partial displacement. Type 4, complete displacement. Another one, craniomaxillofacial injury. This is Lefort classification of facial trauma. Okay, 3 types. Lefort 1 and Lefort 2 and Lefort 3, which is called craniofacial dissociation. To simplify it, you will see this picture. Here is type 1, which starts at the nasal septum, then it goes through the maxilla above the teeth and move backward towards the pterygoid. Okay, this is the type 1. Started from the nasal septum through the maxilla and to the pterygoid. And this is type 2, which is called the pyramidal type. Pyramidal type, which started from the frontonasal ridge, then through the lacrimal bone, then through the infraorbital bone, then passes through the maxilla, and it usually involves the pterygoid plate. Again, from the frontonasal suture, then the lacrimal bone, then the infraorbital margin or infraorbital floor, then the infraorbital foramen, then through the zygoma and maxilla till reach the pterygoid. While in type 3, which is the most important, craniofacial dissociation, the patient will present by complex bilateral fracture of the frontoosmoidal region, superior and lateral orbits. Then it can go laterally through the ethmoid to sphenoid. So in questions, when you see sphenoid to ethmoid, this is a Lefort 3 fracture. Okay, from sphenoid to ethmoid. This is a fracture which is from the frontonasal, then passes laterally, then it takes the whole orbit, then it takes the sphenoid to ethmoid. This is called the craniofacial dissociation, where the cranium is dissociated from the face. This is a craniofacial dissociation. Okay, this is also important question for the classification of the maxillofacial trauma. Another one. This is also an important picture in fracture of C2. C2 is fracture of axis, which is characterized by presence of the dens or peg or odontoid process. What are the classification of the odontoid process fracture? Type 1 is just a fracture in the upper part here. Type 2, junction between the odontoid process and the body of the axis. While type 3 is fracture at the body. The symbol now, fracture of the upper part is type 1, fracture of the junction between the process and body, while type 3 is fracture of the body. This is also important. Another one, fractures to patella. Patellar fracture, the most common fracture for patella is due to direct blow to the patella is a multi-fragmented stellate fracture. Multi-fragmented stellate fracture. This is due to direct blow or direct trauma to the patella. But other types are transverse fracture, vertical fracture, osteochondral sleeve or osteochondral fracture. This is also important fractures. But the most common, which will be asked all over the questions, will be the multi-fragmented displaced fracture, which is called the stellate fracture. These are the tibial fracture. Another one, types of joint all over the body. This is an important picture, and this is usually one question came in the exam every time by types of joints of the body. Initially, I will start between the atlas and axis, which is called pivot fracture. Atlas and axis, which is called pivot fracture, a pivot joint. Okay, this is a type of joint which is called pivot joint. I have two hinge joints at our body, which is the elbow. This is an important. And also I have the knee. Do you know the saddle joint? Saddle joint is a joint between the trapezium of the carpal bone and the first metacarpal. Okay. Also, I have the condyloid joint, which is between the radius and the carpal bones of the wrist, and plane joint, which is between the tarsal bones. Also, we have a pole and socket, which is like the shoulder and like the hip. They are pole and sockets. Then again, the pivot joint between atlas and axis, C1 and C2 vertebrae, hinge joint is like elbow and knee, saddle joint between the trapezium and the first metacarpal bone, plane joint between the tarsal bone, condyloid joint between the radius and the carpal bone, and lastly the pole and socket joint like the shoulder and hip joint. Okay, I'll go for another one. And here is the types of the joints, where they are the synovial or fibrous or cartilaginous. Types of joint are fibrous, cartilaginous, and synovial. Okay, I will clarify the difference between primary and secondary cartilaginous joints, where the primary is called synchondrosis and the secondary is called symphysis. To simplify it, here in primary, where is the articular cartilage is hyaline in nature, like that, like the plate, which is found between the epiphysis and the diaphysis. This is a plate, and it can be ossified after a period of growth. Okay, like this. And also to remember it more and more, this is like the cartilage, which is the costal cartilage of the ribs. So the synchondrosis or the primary cartilaginous joint, where the articular cartilage is hyaline in nature and ossified after a period of growth, and this is like the plate between the epiphysis and the diaphysis and the costochondral cartilage of the ribs. Then the symphysis, this is also an important, which is found like between the symphysis pubis and like the joint between the bodies of the vertebrae, where there is hyaline cartilage also, but in between them there is a layer of the fibrocartilage. Okay, and not ossified after a period of time, and it's called the symphysis or secondary cartilaginous joint, like symphysis pubis or the joints between body of the vertebrae. Also, this is an important question asked. Another one. I have collected some fracture names to clarify for you all. This is a Colles fracture. Colles fracture is fracture of the distal radius. How to remember all of this? I remember them always as a MU and GR. When the Montegia fracture is fracture of the upper ulna, and the Colles fracture is fracture of the distal radius, MUGR. Okay, I will clarify Colles fracture, fracture of the distal radius and dislocation of distal radio-ulnar joint. What is Junsu fracture? I said it. Okay, it's a fracture of the base of the fifth metatarsal. This is Junsu fracture. Also, I called it stress fracture or marsh fracture. This is Junsu. I said it before. Jefferson is fracture of C1, and also we have clarified it before. Jefferson and Hangman. Jefferson is fracture of C1, and Hangman is fracture of C2, and the Clay-Chevalier fracture is fracture of spinous process of C6 and C7. I have clarified it before. Then another fractures, Colles fracture, we know that it is dorsal displacement of the distal segment of the radius, and also it is an extra articular fracture. As I told you, Colles fracture and the reverse of it, which is called the Smith fracture. Smith, both of them are extra articular fractures. Okay, this is a Smith fracture, both of them are extra articular fractures. Hutchinson, which is called Chappell fracture. Hutchinson or Chappell fracture is fracture of the distal radial styloid process. It is the distal radial styloid process fracture, and this is also a question asked. Distal radial styloid process fracture is called Hutchinson or Chappell fracture. Another one. This is an important question also. I see it as the past test, like what is the definition of pannus? Pannus is an abnormal proliferation of the granulation tissue of the synovium. Abnormal proliferation of the granulation tissue of the synovium. Here we are, the vascular pannus. Vascular pannus is associated with the rheumatoid disease. How pannus is formed? Pannus is formed due to release of the cytokines due to chronic irritation. Release of the cytokines causing more and more deposition of the granulation tissue and formation of blood clots, which can be invaded by macrophage and replaced by the granulation tissue. This can occur immediately after fracture due to presence of the hemorrhage or blood clot. Okay, I will see you more pictures to clarify that. Like this. Here is the pannus, okay, which can be formed, or is the synovium here, okay. Then abnormal proliferation of the synovium and deposition of the granulation tissue due to release of the cytokines. Here is the release of the cytokines, okay, like tumor necrosis factor alpha, interleukin B, and some growth and chemokine receptors. No further information for that, just a question came, and pannus is just a question. We will clarify that while discussing, okay? Then now, I have finished clarification. I think I have finished, okay? Now I'm going to discuss questions from the past test. Who is ready to join the discussion? Please raise your hand. Okay, welcome. Welcome, Dr. Mirza. Please unmute yourself. Dr. Noor, welcome.
Am I audible, sir?
Now are you? Yes, you are audible. We can hear you well.
Yes, sir. I'm reading the question. Question number 1. Various fracture patterns result from injurious forces over the patella. Some injuries can be managed conservatively, others require operation. Which one is the most common fracture pattern followed a direct blow, a compressive force to the patella? A. Marginal, B. Osteochondral sleeve fracture, C. Stellate fracture, D. Transverse, E. Vertical. Sir, as you discussed, it's stellate fracture, multi-fragment stellate fracture.
Yes, excellent. This is a multi-fragmented displaced or undisplaced fracture. It's called the stellate fracture, and this is the most common fracture pattern following direct blow to the patella. Other fractures are less common than the stellate fracture. Okay, excellent. Another one. Okay, this question.
Question number 2. An 18 years old man comes to a rheumatology clinic for review. He has suffered recurrent shoulder pain over the past 6 months while playing a rugby scrum. Previously, acute episode of pain resolved, but they are now becoming a chronic dull ache in his shoulder joint. He has no past medical history of note. On examination, his blood pressure is 115 by 70 mmHg, pulse is 60 per minute and regular. General physical reviews unremarkable. Right shoulder abduction is limited by pain.
Okay, what you see in this X-ray?
So this is an X-ray of a shoulder joint.
Can you see the head of the humerus intact?
Sir, head is in
It is some sort of difficult. There is a posterolateral compression of the head of the humerus due to slight anterior dislocation. This deformity is called the Hill sash deformity. Excellent, Dr. Agada. This is the Hill sash deformity. Okay?
Okay, sir.
Hill sash deformity is also a common question asked. And these are the choices: avascular necrosis of the humeral head, congenital malformation of the humeral head, Hill sash deformity, osteoarthritis of the shoulder, septic arthritis. So this is a Hill sash deformity. As I told you, this is a posterolateral compression of the humeral head due to anterior dislocation. Due to recurrent attacks of dislocation, there is like some sort of decreased vascularity and posterolateral compression. Okay?
Okay, sir.
Okay, another one. This one. Okay, Hill sash. Another one.
You examine a patient in the emergency department who has sustained facial injury in a road traffic collision. He has mobility in the palate segment on examination. And the X-ray shows a fracture line passing transversely along the maxillary sinus and pterygoid plate. Which type of fracture it is? A. Lefort 1, B. Lefort 2, C. Lefort 3, D. Lefort 4, A. Craniofacial Dissociation. Sir, it is a fracture passing through the pterygoid plate. Sir, it's Lefort
once you see pterygoid plate, this is Lefort 2. Okay, this is Lefort 2. Once you see sphenoid or isthmoid, this is Lefort 3. I will give you keywords for that. Okay, once you see pterygoid plate, this is Lefort 2. Once you see sphenoid to isthmoid, this is Lefort 3. And there is no Lefort 4. Okay, and Lefort 3 is called craniofacial dissociation or craniofacial dysfunction. So option C and D are the same. Here the correct answer is B, Lefort 2. Okay, another one. Okay, this question.
A 65-year-old woman present to the emergency department with left Colles fracture, having fallen on ice onto an outstretched hand. You attempt to reduce it under a beer block. Considering the process of fracture healing, which of the following is correct? A bone necrosis become apparent within the first 24 hours. B. Initial vascular pannus is formed at the fracture site. C. A lamellar bone is finally replaced by a woven bone. D. Osteoblast lay down seam of uncalcified new bone. E. The provisional callus is made up of lamellar bone. Sir, it's D. Osteoblast lay down seam of uncalcified new bone, which further
right,
forms into a lamellar bone.
Okay, can you tell me what are the stages of bone healing?
So first stage is hematoma formation.
Yes.
And then stage of inflammation, and then stage of callus formation. Then is endochondrial ossification, and then the last stage is remodeling, where it is converted into a lamellar woven bone is converted into a lamellar bone.
Yes, excellent. The first stage is hematoma formation. Hematoma is a mass of clotted blood which occurs at the fracture site, where the fracture site is very painful and with obvious inflammation, and the bone cells are dying in this hematoma formation. The osteocyte and the osteoblast are dying in this process. Then the second process is formation of the fibrocartilaginous callus, which develop over 3 to 4 weeks. And this is characterized by presence of the fibroblast and the osteoblast. And this will be a question came. The fibrocartilaginous callus is characterized by presence of the fibroblast and the osteoblast cell. Then later on, the ponicallus, which started to be present from 4 weeks to 2 to 3 months, whereas due to invasion and the multiplication of the osteoblast and the osteocyte, and where the woven bone is replaced by lamellar bone, not like choice number C. Lamellar not replaced by woven, the reverse. Woven is replaced by lamellar. And then the trabecular bone became compact bone. Later on, the remodeling phase, when any excess ponicallus is removed by the osteoclast for reconstruction and remodeling of the shaft of bone, and this process takes about years. Okay, there are the 4 stages: hematoma, formation, fibrocartilaginous callus, ponicallus, and remodeling. Okay, excellent. So the choice here will be D. Another one.
A patient present to the emergency department following an assault in which he was hit in the face with a cricket bat. On examination, he has facial swelling. X-ray reveals a fracture that passes through the posterior alveolar ridge, lateral wall of the maxillary sinus, inferior orbital rim, and nasal bone. How would you classify this fracture? A. Lefort 1, B. Lefort 2, C. Lefort 3, D. Lefort 4, and nasal fracture. Sir, it is a Lefort 2 fracture, sir, because it's not involving a sphenoidal or ethmoidal sinus.
This a pyramidal fracture, which I said this is Lefort fracture 2, pyramidal fracture, which starts at the frontonasal, then passes through the lacrimal, then through the infraorbital, then through the zygoma and the lateral wall of maxillary sinus. Okay, this is Lefort 2, and this is classified, describes the pyramidal fracture, Lefort 2. Okay, another question. Okay, this fracture.
52 years old cyclist fell off the bike onto an outstretched hand. The falling film was shown.
This is the first film.
Yes, sir. This is some sort of, sir, intra-articular fracture.
There is abnormal thing here.
Yes,
you see
sir.
that?
Intra-articular distal and radius. Most probably, sir, Barton fracture. Or
Okay.
I don't know, sir. Lateral.
I will send another film to see it. Like this. There is abnormal thing here, and there is volar displacement of the distal segment. This is the distal segment which is volar displaced. Okay, while the upper part here is still in place. This is the distal segment is volar displaced, and this is an intra-articular fracture, not extra-articular.
Volar Barton fracture.
Yes, it will be volar Barton. Okay, excellent. As I said, Smith and Colles are extra-articular, and Barton is intra-articular with volar and dorsal. This is a volar Barton fracture. Okay, excellent. Another one. This question.
A 30-year-old woman was admitted 6 hours ago with a comminuted fracture of the fibula. The nurse is concerned that the patient may have a compartment syndrome. Which of those would be the first sign of compartment syndrome? Pain out of proportion, B. Paresthesia of the hallux, C. Pallor, D. Unable to palpate dorsalis pedis, C. Inability to move the hallux. So pain out of proportion of the injury is the first sign and the most significant sign of compartment syndrome.
Yes, we discussed that in the previous lecture, that compartmental syndrome characterized by pain out of proportion to the trauma and paresthesia, tingling, numbness, limited mobility, and the late sign is absent pulse and decreased the blood supply to the limb. Okay, another question. It will be your last question. Then this is compartmental syndrome. This one.
A patient sustained a dislocated shoulder while playing rugby. Before reduction, it is thought that they have an associated axillary nerve injury on examination. What would we expect to find on examination? No sensory loss and weakness of shoulder abduction. No sensory loss over the anterior aspect of the arm, but no motor weakness. Sensory loss over the anterior aspect and weakness of the abduction. The sensory loss over the lateral aspect and inability to initiate abduction. Sensory loss of the lateral aspect of the arm and weakness of shoulder abduction. Sir, E, because there will be sensory loss over the lateral aspect, a regiment badge sign, and there's in weakness of deltoid, so he can't abduct from 30 to 90 degrees. So it should be E, sir.
Excellent. This is the injury of axillary nerve. Injury of axillary nerve is mixed, sensory and motor. Sensory over the upper lateral part of the arm, which is called the patch area, and loss of abduction from 15 to 90, because from 0 to 15 is supraspinatus. Okay, so the correct answer here is E. Another one. Okay, thank you, Dr. Noor. You are really excellent. Who wants also to participate? Dr. Ghada. Hello, welcome, Dr. Ghada. Hello, can you hear me? Okay, Dr. Ilkhan.
Yes, sir.
Hello, Dr. Ilkhan, how are you?
Yes, sir. I'm fine. How it would, sir?
Okay, nice. Then you can continue.
Yes, sir. An 83-year-old man trips while climbing the stair and lands on his right side. He is unable to weight bear, and the right hip is tender to deep palpation. X-ray shows a right undisplaced complete femoral neck fracture. Undisplaced complete femoral neck fracture. What is the most suitable management for this patient? Non-operative management, cannulated screw fixation, sliding hip screw, deep right hip hemiarthroplasty, right total hip replacement. As the patient is 82 years, more than 65 years, less transfer mobility, so my undisplaced complete right hip hemiarthroplasty.
Hemiarthroplasty. So do you remember what I have said in the first? The patient with undisplaced fracture or with displacement if young age. So undisplaced or displaced in young age will be with internal fixation by cannulated screw. This is undisplaced, so I'll go directly for cannulated screw. If displaced in young age, not this patient, it will be also cannulated screw. But if this displaced fracture and this patient is more than 65, I'll go for hemiarthroplasty. Okay? Then the best choice for this patient who is undisplaced will be cannulated screw. Okay? So the correct answer here is cannulated screw. Is this clarified for all? You can see another people saying it is D. No, it is B. It is B. Undisplaced fracture is managed by cannulated internal fixation. Okay, but if displaced and this patient is more than 65, I will go for hemiarthroplasty. Okay, another one.
Yes, sir. A 7-year-old boy presents with a displaced supracondylar fracture of his right humerus. On examination, there is no distal sensory deficit, but he is unable to flex his thumb and index finger to make OK sign. Which nerve has been damaged? Median nerve, option B, radial nerve, option C, posterior interosseous nerve, ulnar nerve, anterior interosseous nerve. OK sign is the functional check of median nerve. Option A, median nerve.
Okay, please keep it from now because you will need this information for part B OSCE also. Okay sign is assessing the integrity of anterior interosseous nerve. Please keep
There
it.
is no sensory loss. Okay, sir. Sorry, sir.
Okay, sign of the flexor pollicis longus and flexor digitorum profundus is assessing the anterior interosseous nerve. Please keep it. Okay, sign is an anterior interosseous nerve. Okay, another one.
An 18-year-old woman falls onto an outstretched hand while playing netball. On clinical examination, she has a full range of movement of the wrist, but tenderness over the anatomical snap box. X-ray are normal. Which one of these would be the most appropriate management option? A. Discharge the patient. B. Open reduction, internal fixation. C. Bone scan. D. Percutaneous screw fixation. E. Thumb spica cast immobilization. Probably patient may be suffer from the scaphoid fracture. That's why thumb spica cast with immobilization it would be appropriate for this patient management. Option E.
Okay, excellent. This is a thumb spica cast immobilization. Okay, regarding the scaphoid fracture, any tenderness over the anatomical snuff box is considered a scaphoid fracture. Okay, due to fear of avascular necrosis, which depend on the radial collateral and the dorsal radial branches of the radial artery. Okay, they reach the tip of the scaphoid. So the proximal area will be the area of least blood supply. And this is the more vulnerable to avascular necrosis. So for fear of this patient, I fear of avascular necrosis of the scaphoid bone. Management of the scaphoid bone fracture will be initially X-ray. If something is abundant, I will deal with it. If nothing is clear in the X-ray, how will I deal with that? You can do two things. The first thing is to put the thumb in thumb spica cast for immobilization. Then you can do any of these two investigations. Pune scan within the first 72 hours, or do an X-ray or CT after 2 weeks. X-ray can be repeated after 2 weeks with prominent criteria, and CT also can be done. Okay, then you manage the patient by initial immobilization with a thumb spica and Pune scan after 3 days, or repeat the X-ray after 2 weeks or CT. Okay, another one. Okay, this.
Yes, sir. A 42-year-old man presents to the emergency department following a high-speed skiing accident. His right knee is swollen. The following X-ray is taken. X-ray of the knee joint showing that there is a multiple line in the medial and the tibial plateau fracture, I think.
Yes, there is something wrong here. Okay.
Type
this
4
is
maybe.
A tibial plateau fracture.
Type 4
okay.
maybe.
Yes, intra-articular tibial plateau fracture. Okay. There is also another classification of fracture, femoral condyle. If there is a fracture here or here of the femoral condyle, which is called Litanier classification of femoral condylar fracture. This is a question asked, but the classification itself is not so important. You just know the name, Litanier classification of fracture of femoral condyle. But here is the intra-articular tibial plateau fracture. Okay, yes, this is also an important question. Okay, there is another one.
A 34-year-old man presents with altered sensation over the medial aspect of his right hand and reduced hand function 3 months after he sustained a humeral medial epicondyle fracture. Examination reveals hypothenar muscle wasting and loss of finger abduction and adduction. Which nerve is most likely be injured in this patient? Radial nerve, proximal ulnar nerve, medial nerve, musculocutaneous nerve, posterior interosseous nerve. I think patient is suffering from ulnar nerve injury because patient hypothenar muscle wasting and loss of finger abduction adduction. There is a
yes, excellent. Hypothenar,
yes, sir.
Hypothenar muscle wasting and loss of sensation over
Sensation
the medial
also.
1.5.
Medial aspect.
Yes, volar and dorsal. Medial 1.5, volar and dorsal. Okay, this is the supply of the ulnar nerve, hypothenar muscle and the medial 1.5, volar and dorsal aspect of the hand. What are the hypothenar muscles?
Hypothenar muscles are the flexor digiti minimi, opponens digiti minimi, and abductor digiti minimi.
Okay, excellent. And what are the innervation of the ulnar nerve also? It innervate all intrinsic muscles of the hand, all interossei
Yes,
and the medial two lumbricals. Because the lateral two lumbricals by medial nerve.
Medial
okay?
nerve.
So
Yes.
all interossei and the medial two lumbricals. Okay, injury of the ulnar nerve causing claw hand deformity. Claw hand deformity. Okay, another question.
A 78-year-old woman is seen in the fracture clinic 5 weeks after sustaining a Colles fracture to her right wrist following a fall. X-ray shows that the fracture is healing well out. On examination, it is noted she is unable to lift her thumb from the table, and when her palm is placed on the table. Which of the following tendon may rupture as a late complication of the displaced Colles fracture? Abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, flexor pollicis longus, and option E, flexor pollicis longus. Patient is suffering from the extensor pollicis longus tendon rupture. Option C.
Yes, excellent. Extensor pollicis longus. And it is one of the boundary of the anatomical snuff box. Can you tell me what are the anatomical snuff box boundaries and content?
Extensor pollicis longus, which is lies anteriorly, and posteriorly lies the extensor pollicis brevis and opponens pollicis longus.
No,
And
not
content
opponens
is-
pollicis. Okay, the extensor pollicis longus is the most medial and it is the most prominent, while laterally is the extensor pollicis brevis and abductor pollicis longus, the first compartment, the first part of the extensor compartment. Okay, the floor of it is the scaphoid bone, and the structures passing through it in the roof is the cephalic vein, and in the content is the radial artery. Content is the radial artery. You can feel the radial artery pulsation in the anatomical snuff box. Okay, and here in displaced Colles fracture, a common avulsion of extensor pollicis longus tendon. Okay, this one.
Following a road traffic collision, a 35-year-old woman who had not been wearing a seat belt is brought to an emergency department with a clear nasal discharge. She undergoes urgent CT scanning from accidental emergency research. Which type of fracture predisposes the patient to cerebrospinal fluid rhinorrhea? Type 1, fracture due to mobility of the teeth. Type 2, fracture of the orbital floor. Type C, type 3 fracture of the ephemoid. D, Lymphoid 4, as it involves the frontal bone. Lymphoid maxillary fracture and not associated with it. There is no Lymphoid 4. Option C, Lymphoid type 3 due to fracture of the ethmoid.
Okay, that's right. Fracture Lymphoid 3 is characterized by, like fracture base of the skull, characterized by CSF rhinorrhea. Okay, craniofacial dissociation, flat face, and CSF rhinorrhea. And Lymphoid 2 is a pyramidal fracture, as I told you, which arising through the maxilla and the tragoid. And in 3, this is a sphenoid and the isthmoid. Okay, can you tell me what are the characters of the fracture base of the skull?
Fracture base of the skull, CSF rhinorrhea. In case of frontal anterior cranial fossa, there may be a CSF rhinorrhea, and the middle cranial fossa, Battle's eye sign or mustard raccoon sign.
Yes. Okay, I shared now a picture of fracture base of the skull. A very important picture. The patient will present by raccoon eye and CSF, rhinorrhea, and otorrhea from the nose and ear. Then the battle sign where there is ecchymosis over the mastoid process, hemotympanum behind the drum, or even blood passing through the air, and the presence of the pump over the skull due to blood accumulation. Okay, continue. Questions? This one.
An 18-year-old rugby player presents to the emergency department with a painful right shoulder. The shoulder is usually square in appearance and cannot be moved without severe pain. Which one of the following statement is most likely to be true? Option A, he has a posterior shoulder dislocation. Option B, require urgent operative decompression to prevent long-term nerve injury. Option C, his arm will be held in a adduction position. Option D, posterior dislocation is a recognized cause of axillary nerve palsy. Option E, he may be treated using Cocker's maneuver.
Okay. Regarding shoulder dislocation, I am going to clarify that. Okay.
Yes,
The
sir.
most common dislocation of shoulder is anterior dislocation. Okay. Then also inferior can occur and the posterior can occur. But the most common is anterior dislocation of shoulder. It is the reverse of the hip. The hip is posterior dislocation, which is more common in hip. But in shoulder, there is anterior dislocation. Okay, you can manage the patient of anterior dislocation shoulder according to Kocher method or the Hippocratic method. What is Kocher method and what is the Hippocratic method? Kocher method, we can do collected them in the word which is called tear. Okay, this is tear of Kocher method. I will do traction, external rotation, adduction, and internal rotation. This is collected in the word tear. Okay, this is attraction, external rotation, adduction, and internal rotation. This is the Kocher method for reduction of the shoulder dislocation, and it will be done under sedation, not general anesthesia. The patient is just sedated, no need for anesthesia for that, just sedation. But the previous Hippocratic methods, to the old traditional method, where the doctor is put his heel in the axilla of the patient and do traction while the patient is still aware of all things. This is a previous method and not used nowadays. Hippocratic methods not used. The Kocher method, which collected in the word tear, is now used. Okay, so the correct answer here will be A. Okay, using the Kocher method. Okay, another one. This question.
A 33-year-old woman was tackled during a game of football and sustained a closed fracture of her distal tibia and fibula. She is admitted to the hospital and has a full cast of the lower leg is applied. Overnight, you asked to review her for increasing severe pain. When you assess her, the pain worsened with dorsiflexion of the hallux. What would be the most appropriate next step in management of the patient? Repeat X-ray, B. Remove cast, prescribe ibuprofen, review again in 1 hour. E. Prepare for theater for fasciotomy. I think patient may develop compartment syndrome. That's why there is so pain. To remove the cast is the next immediate management would be. Then prepare for fasciotomy.
Yes, this patient has compartmental syndrome. So the first thing to be done for this patient is removing the cast and assessing the pulse of the patient. Later on, if there is severe pain not relieved after removing the cast, I will prepare the patient urgent for fasciotomy. Okay, so my next step will be removal of the cast because the cast may be compressing tightly on the limb and causing this pain. But if I remove the cast and this pain is still present, I will prepare the patient for urgent fasciotomy now. Okay, but the initial step will be removal of the cast and assessing the pulse. Okay, another one. This.
Question number 20. A 33-year-old presents to emergency department after a high-speed skiing accident. The right leg is obviously deformed. Following X-ray taken.
Okay, you can see this picture.
There is a fracture in the distal aspect of the tibia and oblique.
Tibia,
fracture.
not tibia. This is a fracture, compound fracture shaft femur. Compound.
Sorry, shaft femur. Sorry, lower aspect of the distal aspect of the femur.
Yes, excellent. Okay, this is a fracture of femur shaft, and this is penetrating through the skin, so it is a comminuted femoral fracture. Okay, this is a comminuted femoral fracture. Another one. And here are the choices. Comminuted distal femoral fracture. Okay, this is a comminuted distal femoral fracture.
A 34-year-old man presents with cervical spine tenderness after being involved in a road traffic collision. He reports serving suddenly to avoid a child on the road and colliding with a parked car. He admits not wearing a seat belt and injuring his chin as he fell forward onto the dashboard with his neck hyperextended. Which fracture pattern is most likely to be seen on the X-ray? Hangman fracture, Jefferson fracture, type 1 odontoid fracture, type 2 odontoid fracture, and type 3 odontoid fracture. Uh, this is Jefferson fracture, option B.
Jefferson fracture is fracture of C1. When you hyperextend the neck, you will cause fracture of C2 of axis. This is a hangman fracture. Okay, this is hangman fracture due to hyperextension of the neck. Jefferson fracture. Do you remember types of odontoid fracture? Type 1,
Odontoid
fracture
fracture
of the
type
dents.
1, there is a tip of the odontoid process involving
Yes.
the type 1 fracture. Type 2, in the junction between the odontoid process and the body of the axis is called type 2, and involving the through the axis is type 3.
Yes, the body is type 3. Okay. Thank you. Excellent, Dr. Al-Khan. Who wants to participate again? Please raise your hand. Okay, Dr. Noor.
Yes, sir. In secondary bone healing, which are the main cell involved in the soft callus formation? Monocyte, neutrophil, C, osteoblast and fibroblast, D, osteoclast, E, plasma cell. Sir, it's osteoblast and fibroblast because fibroblastic proliferation occurs in callus formation.
Yes, excellent. Soft callus is the fibrocartilaginous callus. So the cells are fibroblast and osteoblast. Fibrocartilaginous callus started to develop within 3 to 4 weeks period of the trauma. So the correct answer here is C. Excellent. This one.
A 19-year-old student falls awkwardly and sustained a closed elbow dislocation. He has sensory loss over the hypothenar eminence and a little finger, loss of abduction of the index finger, and loss of flexion of the little finger. He has normal wrist extension and normal flexion of position and abduction of thumb. He has normal movement and sensation around the shoulder. Which of the following nerve will be affected? So it's ulnar nerve because there is a loss of sensory loss over the hypothenar eminence and little finger, but because he can do wrist extension, so radial nerve is intact, and there is a normal movement around shoulder joint and normal movement around the radial side, so median nerve is also intact.
Yes, excellent. Due to loss of sensation over the hypothenar eminence, as I told, the medial 1.5, volar and dorsal parts, and also loss of abduction, while loss of the abduction of the index because of the palmar interossei. Palmar interossei causing adduction and dorsal interossei causing abduction. In this abduction due to dorsal interossei, okay? Dorsal interossei are lost because all interossei are supplied by the ulnar nerve, while the medial 2 lumbricals are supplied also by the ulnar, but lateral by the medial nerve. Okay, another question. Medial nerve are collected in the word loaf, lateral 2 lumbricals, opponens pollicis, abductor pollicis, and flexor pollicis brevis. Okay, another one. This question.
A 85-year-old woman is admitted through casualty with a classic Dana-Fox deformity on her left hand. She tripped and fell the previous night using this hand to break her fall. What is the most appropriate management of a Colles fracture? A dorsal backslap following reduction with the distal fragment in palmar fraction and radial deviation. A following reduction, a dorsal backslap applied with the distal fragment in palmar fraction and ulnar deviation. A volar backslap with a distal fragment in palmar flexion and ulnar deviation, manipulation under general anesthesia. So we do it with because it is dorsal and because the Colles fracture is a dorsal displaced and radial displaced, so we reduce it in the palmar flexion and ulnar deviation. And sir, it should be a dorsal backslap with it should be B, sir.
Yes, excellent. As I told before, Colles fracture, the distal segment is displaced dorsally with radial deviation and impaction. So when I reduce this fracture, I will do forward flexion or palmar flexion and ulnar deviation I will put the slab backward, not volar. I will put the slab dorsal. So the slab will be dorsal and the distal fragment is pushed towards the palm by palmar flexion and ulnar deviation due to radial displacement. So the correct answer here is B. Excellent. Another one. Salter-Hurst classification.
7 years old boy is tackled during a game of football and sustained an injury to his right ankle. An X-ray shows a fracture through the growth plate and epiphysis of the distal tibia. It is Salter-Harris. So it is going through Salter-Harris type. Type 1 is when it's the physis is compressed, and so Salter-Harris type first is slipped, sir. Type 2 is going above, and type 3 is going below, and so it is type 2, sir. It is going above towards the epiphysis.
Oh, okay. Then type 2 is the metaphysis. Type 3 is the epiphysis.
Okay,
so this is type 3. Okay.
Okay, sir.
Then type 2 below is the metaphysis, and the type 3 is above to the epiphysis. Then remember 3 with double E, it will be epiphysis. 3 with double
Okay,
E,
sir.
it will be epiphysis. Okay. Another one. This.
A 21 years old student presented to the emergency department with a painful swollen ankle after tripping downstairs while intoxicated. The following X-ray is shown. Sir, it is
What
bimalar
do you
fracture.
see?
It is fracture of the medial malleolus and along with fracture of the
Medial? Is this
and
medial
lateral
malleolus?
no, it's
Lateral.
bimalar fracture, sir.
Lateral malleolar fracture according to Weber classification. It is
No,
Weber
sir,
1 or 2 or 3, Weber A or B or C.
It's Weber C, sir, because it's going above syndesmos.
Yes, it is Weber C. Excellent. It will need an internal fixation by open reduction
Yes.
and internal fixation. Okay. And here are the choices. Weber C. Okay. Associated also with medial malleolar fracture. Can you see it? Okay, another one. This question.
A 23 years old presented with a humerus fracture on the left side affecting the area of the spiral groove. They have focal neurological deficit on that side, but no vascular compromise. Which nerve is most likely to be injured? So it is because most probably the injury is in radial groove, so it's a radial nerve fracture. Because
Okay.
fracture
Yes, excellent.
is around the humerus.
Regarding fractures of the humerus. Fracture neck of the humerus is classified according to Neer classification. Neer classification, okay? Neer classification is depends on the 4 segments which are fractured. Medial, greater tuberosity, lesser tuberosity, surgical neck, and anatomical neck. This is the Neer 4 segment classification of the fracture neck of the humerus. Okay, then during the fracture neck of the humerus, there is an axillary nerve and axillary vein injury. And this is also a question asked. Fracture neck of the humerus, which passes in the triangular space, causing axillary nerve injury. Okay, then in the radial groove, where it passes the radial nerve and the profunda brachii artery. Okay, radial nerve and the profunda brachii artery in the radial or spiral groove. Okay, so in this patient, in the area of the spiral groove, the radial nerve will be affected. What will happen if the radial nerve is affected at the level of the spiral groove?
Wrist drop will be there, sir. Finger drop will be there, and there is loss of sensation over the extensor dorsal aspect of the hand.
Excellent, because of supply of the triceps is above the level of the spiral groove in the axilla. So the triceps will be spared. So there is no elbow drop. There will be loss of wrist drop and finger drop, loss of wrist extension and loss of finger extension. Okay, then I will repeat again. Fracture of the neck of humerus. They are classified according to Neer 4 segment classification. Greater tuberosity, lesser tuberosity, and the surgical neck and the anatomical neck. Injured vessels and nerves in this fracture are the axillary nerve and the axillary vein. The axillary nerve is more common, but in the spiral groove or the radial groove of the humerus, there is injury to the radial nerve and the profunda brachii artery. Both of them pass through the triangular space. As you remember, the quadrangular and the upper triangular and the lower triangular intervals. Okay, in the lower triangular interval, the radial nerve and the profunda brachii artery passes through it, then hook around the spiral groove. In this patient, there will be affected of the radial nerve. So there will be no loss of the triceps supply because the triceps is supplied from above. When injury to the radial nerve in the spiral groove, there is wrist drop and finger drop. Okay. Another picture. This question. I think Colles. Okay. This one.
A 7-year-old boy fell off the monkey bar, landing on an outstretched right hand. X-ray shows an ulnar fracture with dislocation of the radial head. Which type of fracture is this? Fracture of ulnar fracture with radial head dislocation. It is a Monteggia.
Okay, this is a MUGR.
Yes.
Monteggia fracture is fracture upper part ulna. Galeazzi fracture is fracture of the distal radius. Okay, MUGR. Okay, so this patient has a Monteggia fracture, so it is the upper ulna. Okay, remember this. Another one. Castello-Anderson classification of open fracture.
A 28-year-old man jumped approximately 6 feet from a wall and has sustained an open fracture of the left ankle. The open area is 5 centimeters. There is moderate combination, local skin coverage, no free flap, and no vascular repair is required. In accordance to Castello-Anderson classification, which type of open fracture it is? So because it is around between 1 to 10 centimeter, and the flap and no vascular injury is there, so it is a type B, type 2 injury.
Yes, excellent. This is type 2. We said before, type 1 less than 1 centimeter, type 2 from 1 to 10, type 3A with minimal periosteal stripping and minimal need to tissue coverage, type 2B with significant periosteal stripping and severe imminent need for tissue coverage, type 3C is vascular compromise. Okay, and this is excellent. It is 5 centimeters, so it will be Castello-Anderson classification type 2. Another one. This.
You are sitting in with a pediatric orthopedic consultant. They ask you about what injuries you are likely to see in clinic. Which one of the following is a fracture that most commonly present in childhood? Barton-Colles fracture, fracture of the femur shaft, hairline fracture of the temporal bone, supracondylar fracture. So supracondylar fracture is the commonest fracture under 12 years of the child.
Excellent. This is due to high violence trauma in children less than 12 years. There is common supracondylar fracture. Supracondylar fracture causing injury of the brachial artery with absent pulsation distally, and the most common injured nerve in supracondylar fracture is anterior interosseous nerve of the OK sign. Remember that, the anterior interosseous of the OK sign. So you will lose the OK sign by flexor pollicis longus and flexor digitorum profundus of anterior interosseous nerve. Okay, really excellent, Dr. Noor, thank you. Who also want to participate? Okay, welcome, Dr. Ghada.
Finally, thank you.
Okay, this question. This one.
A 30-year-old man is brought to the emergency department requiring assessment for an open femoral fracture. Which one of these is correct regarding open fractures and their management? A can be classified using the Salter-Harris classification system. B, not all open fractures require antibiotics. C, all patients require tetanus prophylaxis. D, compartment syndrome cannot occur in patients with open fracture. And E, bone fragments without soft. Sorry. Okay, the first one, Salter-Harris, it's for the growth plate fracture classification, and Castello, it's for open fracture classification. In open fracture, there is risk of infection, so B, it's not right because we need antibiotics. But C is right, tetanus prophylaxis for patients. But I can't see the last option.
For all patients, you will give tetanus prophylaxis?
No, because I didn't see the last one. Yes, now it's apparent. because of options, it can't be revealed.
Okay.
Only fragments without
Prophylaxis
salt.
is a vaccination. Okay. Tetanus
According-
prophylaxis depends
according-
on the previous
Tetanus
vaccination schedule.
prophylaxis, according to the schedule, if
Yes.
there is no, can you just read the E option because it's so multiple messages, so it's not relevant here.
Okay. Bony fragments without
Yes.
soft tissue attachment should be removed. Any bone fragments
Yes,
should be removed because they became now a vascular.
This makes sense now. When fragments without soft
Yes,
tissue
yes.
attachment should be removed. Yes, this makes sense now. Yes.
Okay,
Because
that's
compartment, yes, because compartment, it can occur even in open fractures. It can occur. It's a matter
Yes.
of pressure inside.
Excellent. Compartmental syndrome can occur even in compound or open fracture.
Yes.
Okay, another question. This one.
A 45-year-old woman is admitted after a fall into her elbow, resulting in a fracture of olecranon. She has difficulty fully extending the joint. Regarding the classification of joints, which one of the following statement is correct? A, fibrous joints are very mobile. This is not correct. Fibrous joint, there's no mobility. B, primary cartilaginous joints unit the bone of the vault of skull at the sutures. No.
Vault of skull sutures are fibrous joints.
Yes,
Okay.
they are not a cartilaginous type.
Yes.
C, symphysis pubis is an example of synovial joint.
No, symphysis pubis is
symphysis in the middle part of the body. It's not
secondary.
type of,
Secondary
yes,
cartilaginous
secondary
callus.
cartilaginous. Yes.
Excellent.
Not,
Okay.
the synovial joint have a capsule enclosing the joint cavity. This is right. This is the prominent feature of synovial joint. Cartilaginous epiphysis is a highly vascular structure. No, cartilage has no blood supply within itself. So
Yes.
D is the option.
Yes, right. So synovial joints have a capsule enclosing the joint cavity. Yes,
Yeah.
right. Salter-Harris classification has been discussed. This.
Okay, a young boy has sustained a fracture involving the growth plate of his left ankle. Which one is correct regarding growth plate fracture? The least common would be Salter-Harris type 1 fracture. Growth plate fracture are more common in girls. The most common would be type 2. This is correct. Infection is the most concerning complication associated with fracture, and all fracture involving growth plate require surgical. Well, it's more common in boys, so B, it's not correct. Most common type is the type 2, C is correct. Most concerning complication is growth arrest when there is
Yes.
crush injury. Not all types require surgery. It's the crush type and the second type, 2 and 5 require surgery. The least common, I think it's the third type when there is injury to the growth plate with epiphysis. It's the least common, type 3, not type 1.
Okay, then the right answer here is C. The most
Let's
common
see.
is type
Common
2,
is type
5%, 75%. Okay,
Yes.
and the least common is
I
by
think type
1%.
3 type 3 is the least common.
Okay, no, this is type 5 by 1%.
Okay, type 5, crush injury, yes.
Okay, then another one.
5 is the least and is the worst. There's the growth arrest, and will be a discrepancy in the length of both limbs.
Yes, then this question.
Okay. 79-year-old woman suffers a displaced transverse fracture of her left olecranon. The fracture is treated conservatively in a cast. Which function is she most likely to have difficulty? Brushing her hair, fastening buttons, pouring a kettle, pushing to stand from armchair. And E, I can't see the E, but D is correct. It's a fracture in the olecranon. And
Okay, olecranon is the attachment of the triceps muscle.
Triceps.
Insertion of triceps is on olecranon process of the ulna. So when you push to standing from an armchair, then you use your triceps muscle.
Posterior compartment of the arm,
Okay.
so you cannot use.
But brushing hair and pouring cattle, they are the shoulder movement, and the fasting cotton is the wrist and hand movement. Okay. Another questions?
Okay.
This one.
Children's bones are more elastic than adult bone. The injury patterns in this patient group are therefore different to those in fully mature skeletons. Which particular type of fracture affects elastic bone? Colles, no. Gileasi, Montegia, tibial, tubercle apophysitis. You said this type before. I can't see the E type. Can you just read the E option?
Yes, torus and green stick fracture. Torus is buckling of bone.
Green stick, yes. This is the option.
They occur in children because their bones are malleable.
Malleable bones.
Okay. Torus and green stick fractures.
Cortex. Yes, only one cortex is involved. So torus and green stick, option E.
Okay, remember in children, torus and green stick fracture, and also supracondylar fracture is less than 12. There are two common fractures in children. Supracondylar, torus and green stick fracture.
Torus and green stick. A 24-year-old man is found unconscious outside a nightclub. On examination, blood pressure is 118/84, pulse is 92 per minute, and Glasgow Common Scale score is 3. He smells of alcohol and he has bilateral periorbital hematomas of the left mastoid bruising. There is discharge of blood mixed with watery fluid from his left nostril and ear. Otoscopic examination reveals blood behind the tympanic membrane. This feature of basal skull fracture. Most likely diagnosis in this, it's B, basal skull fracture.
Yes, excellent. Basal skull fracture is characterized by a bump which is found over the forehead, raccoon eye, CSF rhinorrhea and otorrhea, and also patel sign, which is bruising over the mastoid process, and hemotympanum. Okay, another one. This one.
You are sitting in the pediatric orthopedic consultant and they ask you about what injuries you are likely to see in the clinic. Which one of the following is a fracture the most commonly present in children under 12 years old? Supracondylar fracture.
Yes, this is a repeated one, supracondylar fracture. Okay.
Sir, I want to ask about the hairline fracture. What is hairline fracture, please?
Yes, hairline fracture is like a green stick fracture, just a simple cortical disruption of the bone. I will show a picture for it. Okay, and this one.
A type of pathological fracture or...
Okay, you see that?
Okay. The optimal surgery for neck-of-femur fracture depends on the nature of injury. A fractured neck of femur in the right leg of 75-year-old woman is described as a complete fracture through the femoral neck with partial displacement. According to the Garden stage classification, this feature should be classified 1, 2, 3, 4. Okay. There is femoral neck fracture with complete with partial displacement, type Garden 3.
Yes,
C.
types.
Not complete. 3. Yes, not. I mean, not complete displacements. Complete fracture without.
Okay, can you tell all Garden classification?
Yes. The first, there is no complete fracture without displacement or angulation, and then in type 2, complete. No. I just
focus. Okay, non-displaced is type 1. Non-displaced.
No angulation is.
Incomplete fracture is type 2. Then complete with displacement is type 3. Complete with displacement is type 4. Okay. Okay. Yep. Then undisplaced type 1. Okay.
And then displacement incomplete fracture.
Incomplete, yes, is type 1. Complete but no displacement is type 2. Complete with partial displacement is type 3. Complete with complete displacement is type 4. Okay? Displacement in type 3 and 4. No displacement on type 1 and 2. Okay, this question?
Okay.
Jefferson fracture.
Okay, you are treating a 24-year-old man who has been injured in a high-speed traffic collision CT scan of head and neck reveals Jefferson fracture. What is Jefferson fracture? We said that Jefferson is C1, Atlas fracture.
Yes,
The
Atlas fracture is C1.
blow
Axis
fracture of the
fracture is called
hangman fracture.
hangman. Okay,
The
excellent.
blow fracture of the odontoid transverse.
Okay, another question. This one.
You are reviewing an elderly patient in a fracture clinic with non-union of a humeral fracture. During fracture healing, which one of the following observation is correct? A vascular pannus is formed initially at the fracture site. It is callus, not pannus. Bone necrosis is not a normal part of fracture healing. I'm not sure. Osteoclast.
No, I told in stage of hematoma,
there is
bone
necrosis,
necrosis.
right?
Yes,
Yes.
remember it.
Yes. Osteoblast laid the bone, not osteoclast, and provisional callus is made up of woven bone. Woven bone finally replaced. I want to read.
Woven bone is
lamellar-
replaced by lamellar bone.
Lamellar bone. This is true. Woven bone is first, and lamellar bone is the net result. So E.
Yes,
E is true.
excellent. Woven bone is replaced by lamellar bone, and the trabecular bone is replaced by compact bone. Keep
Compact
this.
bone.
Okay. Another
Okay.
one. This one, garden again.
Okay. 80-year-old woman is brought to the emergency department following a fall. She is unable to weight bear. AP X-ray shows an undisplaced intracapsular fracture neck of Humerus completely extend across the neck. Complete undisplaced is class 3, garden 3.
No, I say displacement from 3 and 4. Non-displacement 1 and 2. Displaced in
Okay.
3 and 4.
I want to write them. Can you just write me down? The first is undisplaced
Okay.
only.
Yes, undisplaced, incomplete. Okay.
Incomplete.
And garden 2 is undisplaced also but complete.
Complete. Oh, okay. Complete.
Then
and
garden 3 and 4, displacement, partial and complete. Okay. 1 and 2, no displacement.
1 and 2, no
3 and 4,
displacement.
displacement.
Okay, okay.
Okay, this is garden 2.
Garden 2.
Correct answer here is B. Okay, excellent. Another one. Yes.
77-year-old woman with a history of hypertension sustains a left neck of femur fracture and is being considered for surgery. Which one of these options is correct regarding measurement of this patient? Opioid would be the most suitable first-line analgesia. Surgery should be performed at 48 hours of injury. She should have CT to aid surgical planning. She should be consulted regarding the options of a spinal or general anesthetic. She should receive fascia iliac block. I think she can be consulted about the type of anesthesia, either spinal or general anesthetic. Because
Yes.
opioid is not the first line. We can start with simple analgesic.
Why?
Like paracetamol.
We are going according to, yes, WHO analgesic ladder.
Pain ladder. We start by simple analgesia and then non-steroidal, and the third line will be opioid.
Yes.
Surgery within 40.
Weak opioid like codeine is the third line, and the fourth line is a strong opioid like morphine.
Yes, yes, exactly. And the surgery after 48 hours of injury, I think must be
after
earlier.
36. After 36. Okay,
Yes,
within 36.
36, yes, 36 hours. And
okay, when to do CT for this patient?
Yes, CT scan for such a kind of patient is not nonsense, because
okay, let's clarify some questions for others because they are asking. Okay, the WHO analgesia ladder. We are going for any pain management, and this is an important station for Part B OSCE. This is a single station in critical care and surgical science. Pain management will going according to the WHO ladder. Okay, we start by paracetamol and add on non-steroidal in type 2. When you go above, we will go with weak opioid like codeine. When you go above, we will give a strong opioid like morphine and Distal. And when you go above, you will give the patient epidural or patient-controlled analgesia. This is the WHO ladder. I will start by simple analgesia like paracetamol, then I will add non-steroidal, then I will add simple opioids like codeine, then I will add strong opioid like morphia or pethidine. Later on, I will do epidural analgesia or patient-controlled analgesia. This is the WHO ladder. I will send it on the group, okay? When to do CT for a patient with fractured neck of femur, when I am suspecting and I am sure in clinical examinations there is fractured neck of femur and it is not seen in the X-ray, I will do CT. CT is not done for every patient with fractured neck of femur. I will do it when the X-ray is normal and I am suspecting the fractured neck of femur.
Yes.
Okay, and this patient have a history of hypertension and 77 years old, so I will counsel the patient for preoperative anesthesia fitness. So the correct answer here is D. When to do fascia iliaca block? As I told you, like epidural and patient-controlled analgesia. This is the last thing
option
to be done when the patient has a pain. Okay, so not everyone is given opioid, not everyone is given fascia iliaca block. Okay, another one. This is simple.
Okay, what's the type of fracture is this? An 82-year-old woman falls on her garden onto a flexed right wrist. An X-ray reveals a fracture of distal radius with volar angulation. Okay, volar. If volar angulation, this is not Colles, the reverse Colles. Smith fracture, right?
Reverse Colles is?
Smith or Barton?
Smith.
No, Smith is the reverse Colles.
Yeah.
It's also extra capsular, extra articular. Yes, and Barton, it's either Colles or Smith fracture with angulation. So it's
with intra-articular extension. Volar?
Yes, volar or dorsal.
What Chappell fracture is called Hutchinson fracture.
Hutchinson,
okay?
Yes.
This fracture of the radial styloid process.
Styloid radial fracture.
Okay, what do you remember Binet and Ronaldo fracture, which I said in the first?
Yes,
this is a Binet and Ronaldo.
Binet fracture, there is inability to extend the distal pharyngeal joint.
This is the fracture of the base of the first metacarpal bone. When it is intra-articular fracture, both of them are intra-articular. When it is simple and radial, it is called Binet. Ronaldo fracture is a comminuted fracture of the base of the bone.
Binet is a simple oblique fracture of first metacarpal.
Yes, excellent.
Oblique.
I will collect all of fractures, the name and the description in a simple paper, and I will send it to you. Okay?
Yes, hopefully.
Okay, another one.
Which one of the following eponymous fractures best describe this pattern? A 75-year-old woman presents to accident and emergency having tripped at home and fallen into her outstretched left wrist. On examination, there is marked swelling and tenderness over the left wrist. An X-ray confirmed distal radius fracture. The distal fragment is shifted and tilted dorsally, radially, and impacted. Colles fracture.
Yes, excellent. This is a simple description of Colles fracture. Distal radius is displaced dorsally. Yes, perfect description.
An elderly female also.
It will be not easy like that in the exam. I think it will be more difficult. Okay, another one.
Don't terrify me, please.
Okay, this question. Near classification of fracture humerus.
Okay, 56-year-old woman is violently pinched forwards and falls into their left outstretched hand. They are found to have fracture of the surgical neck, near classification group 2. Okay, we said at surgical neck, there's injury to the axillary artery, axillary nerve and vein. So axillary, D is the axillary nerve.
Nerve is the most common and the most important. Axillary nerve is more common to be injured than axillary vein. Okay.
Weakness of deltoid and loss of sensation in the regimental pouch area.
Yes, excellent. Sensory and motor innervation of the axillary nerve. But radial and the profunda brachii artery are injured in the radial
spiral groove.
Okay, excellent. Another one. No, we said that before. I'll share the last question. It's 45. Okay.
Which one of the following is the anatomical description of a Smith fracture? Okay, Smith is The reverse Colles
Intra-articular or
fracture,
extra-articular?
it's like Colles, extra-articular, okay?
Yes.
Distal radius with the volar displacement. Yes.
Yes.
See, it's an extra-articular distal radial fracture with volar displacement.
Yes, this is a simple برضو classification of the Smith fracture, extra-articular distal radial fracture with volar displacement. Okay, then I'm going to discuss some questions also collected from other books. That who is interested to share, please raise your hand.
I'm raising my hand already.
Okay, this question, hand conditions.
Okay, hand conditions.
And we can start with a new one, then
Okay.
we will come back, okay?
Okay.
Okay, thank you, Dr. Reda.
Welcome.
Dr. Naim, okay, can you hear us, Dr. Naim? I think you have no mic. Dr. Al-Khan, unmute. Okay, we are going to discuss hand condition.
A 74-year-old man presents with inability to extend his ring finger. On examination, his ring finger is locked in flexion, but can be released with manipulation.
Okay, this describing what? Inability to extend the ring finger, but it is locked in flexion. This is called a trigger finger. Okay, trigger finger, which is locked in flexion and causing some tricky sound on extension of the finger, and more common to occur with the ring finger. Okay, inability to extend the ring finger and locked in flexion, this is a trigger finger. Okay, so one is B.
One is
Two.
B. Two, a 42-year-old woman presents with a firm swelling over dorsum of the wrist. It has been fluctuating in size, causes discomfort when typing. Like decubital synovitis?
No. Okay, then the swelling which present on the dorsum of the wrist and it is fluctuating. This is typically description of the ganglion. Typically description of the ganglion. Ganglion is a cyst filled with synovial material due to hypermobility of the joint, causing bulging of this cyst over the extensor surface or the flexor surface. Okay, this is a ganglion. Simple ganglion or compound ganglion are structures found related to the wrist joint or even the foot, but more in the wrist. Okay, the firm swelling and fluctuant. Okay, so 2 is G. 3.
3. A 36-year-old woman presents with a pain over the radial aspect of the wrist. Radial aspect of the wrist. On examination, pain is elicited by force adduction and wrist of the thumb. Force adduction, flexion of the thumb. It is maybe a Scaphoid fracture.
No, this is what's called stenosing tenovaginitis. Or sign. Okay, Stein sign is a stenosing tenovaginitis due to of the tendon of the extensor pollicis brevis and abductor pollicis longus, the first compartment of the extensor compartment. Okay, and it is the lateral boundary of the anatomical snuff box. It is called the Kervian stenosing tenovaginitis, and this sign is characteristic for this Kervian tenosynovitis, so it is called the Frankenstein sign. Keep it. Frankenstein sign is suggestive of the Kervian stenosing tenovaginitis. Inflammation and thickening of the first compartment of the extensor compartment, which is the lateral boundary of the anatomical snuff box. Extensor pollicis brevis, abductor pollicis longus. Okay, and it can be managed with corticosteroid injection and rest with a splinting of the tendon sheath. Okay, another question. So 3 is F. 4.
For a 24-year-old presents with pain and swelling over the base of the thumb following a skiing accident. His grip is weak. This is Scaphoid fracture.
Yes, this is also a difficult question. It is called a gamekeeper thumb. What is a gamekeeper thumb? Is injury to collateral ligament of the thumb. Gamekeeper thumb is called injury to the ulnar collateral ligament of the thumb. Okay, repeated trauma or repeated microtrauma during sport or during playing game causing injury to the ulnar collateral ligament of the thumb. It is called the gamekeeper thumb. So 4 is D. These questions are very important.
It's very difficult.
Hand conditions are very important and very difficult. Please keep this. Trigger finger, keep it. Ganglion, keep it. Decurvian, stenosing tenovaginitis, keep it. Okay, they are very important. Okay. And ulnar collateral ligament injury. Gamekeeper thumb. Okay, another one. Will you continue or you shocked from the previous questions?
It's shocking. I give all the questions wrong.
Okay, we can continue.
A 25-year-old man presents with a blue right arm with absent radial pulse and painful passive finger extension following a supracondylar fracture of the humerus. This is a compartment syndrome scenario, I think.
Yes, right. 1 is compartmental syndrome. Okay, 2.
To a 40-year-old woman presents with a 5-week after a radial fracture with a painful swollen hand. The hand is cold and cyanosed with a heightened temperature sensitivity.
This syndrome is called psoriatic atrophy.
Psoriatic
or
atrophy, yes.
complex regional pain syndrome due to sympathetic overactivity, causing severe pallor, severe pain to the limb. Psoriatic atrophy or CRBS, complex regional pain syndrome. Okay, due to sympathetic overactivity. So 1 is A, compartmental syndrome. 2 is H, psoriatic atrophy. Okay, 3.
3. A 70-year-old woman complains of right-sided pleuritic chest pain and 10 days after a fractured neck of the femur. It might be a pulmonary embolus. Option E.
Yes, excellent. 4.
Yes, sir. A 60-year-old woman complains of pain and swelling and reduced mobility 4 months after suffering a fractured tibia, and X-ray shows absence of callus at the fracture site. This is a case of delayed union.
Delayed union, yes, right. Okay, we have time for fibrocartilaginous callus about 3 to 4 weeks. Then the ponycallus 2 to 3 months. Here in this patient, 4 months and there is no fibrocartilaginous callus or ponycallus. This is a delayed union. Okay, 4 is G, delayed union. 5.
Delayed union. 5. A 65-year-old woman who falls on her outstretched arm has weakness in wrist extension. Weakens wrist extension. It is
Loss of wrist extension is
a radial nerve injury.
yes,
radial
nerve injury at
L.
the spiral groove. At the spiral
Yes,
groove.
sir.
Okay, excellent. Another question. This one, management of fractures.
Yes, sir. A 24.
Okay, sorry. Okay, again.
Yes, sir. A 24-year-old man presents with a sore and painful hand after falling over playing squash. X-ray reveals a scaphoid fracture. Long thumb spica cast. Option I.
Option I, excellent. Okay, as I told you, you have suspected
Yes,
scaphoid fracture, so we will do some spica immobilization costs. Okay, 2.
Yes. A 75-year-old woman presents to accident and emergency after growing pain and inability to bear weight following a fall. X-ray reveals an undisplaced fracture of the superior pubic ramus.
This is undisplaced fracture pelvis. Okay, undisplaced. No. Hip spica can be used in vertical shear or even open book fracture pelvis. We do hip spica to control the hip until continual management. But in this patient have just superior pubic ramus fracture. So the patient can be managed conservatively with analgesia and encourage weight bearing. Okay, with analgesia and encourage weight bearing. This is a simple fracture of pelvis. All fracture pelvis can be managed conservatively except if the patient has associated vascular or viscous injury, like bladder or urethral injury. Okay, so analgesia and encourage weight bearing. So 1 is I, 2 is G.
3.
A 65-year-old woman presents with a displaced extracapsular fracture of neck of the femur. Management would be internal
As I
fixation.
told, if undisplaced or displaced, we can do cannulated screw. Undisplaced or displaced, we can do cannulated screw. Okay? This will be internal fixation. Internal fixation with cannulated screw. Okay, excellent.
Question number 4. A 35-year-old woman presents after a fall on an outstretched arm. X-ray shows a minimally displaced surgical neck fracture of the right humerus. This may be collar and cuff sling.
Yes, right. Minimally displaced means there is no massive displacement, so it can be managed conservatively with collar and cuff sling. Okay, so 4 is B. Okay.
And so question number 5. A 75-year-old woman presents to accident at emergency with a displaced Colles fracture. Displaced Colles fracture should be managed with complete practice now. Broad arm sling, option C.
No, you have to put pack slab. You have to put pack slab, not a sling only. In this patient, you will put a slab due to dorsal angulation, so there will be palmar flexion and ulnar deviation to the distal
option
segment.
H, sorry.
Yes, and to put a pack slab. Okay, then manipulation under anesthesia and giving and to put pack slab. So 5 is H. 1 is I, 2 is G, 3 is F, 4 is B, 5 is H.
5 is H. Okay, sir.
Okay. Who wants to participate? Types of fracture. This is an important one. I think is the most important to come in the exam. Okay. If anyone also want to participate. Okay, you can. Oh, there is a new one. Sorry, there is a new one. Can participate. Dr. Noor, Dr. Ghada, Dr. Al-Khan, I think you are answering all the questions. Okay. If anyone also wants to participate, if nothing, I will continue with Dr. Al-Khan.
Okay, sir. A 24-year-old woman presents with pain in the wrist movement after falling on her hand. On examination, there is a tenderness and swelling on the anatomical snap-off. This is a typical history of scaphoid fracture.
Yes, this is scaphoid fracture. Excellent.
Option F. Question number 2. A 68-year-old woman presents with a fracture of distal radius with dorsal displacement of the distal fragment after a fall. It is a history of Colles fracture.
Colles fracture.
Option
okay.
A.
Yes.
3. A 7-year-old boy presents with a swollen, painful elbow following a fall. He is unable to move her arm due to pain. It is a history of supracondylar fracture is common.
Yes, as I told, supracondylar fracture is more common in children less than 12. Here is a 7-year-old boy with painful swollen elbow. This is a supracondylar fracture. Okay.
Yes, sir.
4.
Question number 4. A 19-year-old rugby player falls on a backward stretched hand and presents with a loss of shoulder contour and absent sensation in the military badge area below the shoulder. It is a history of surgical neck of the femur fracture.
I said with dislocation shoulder, anterior
posterior dislocation of the shoulder. Posterior dislocation of the shoulder.
No, anterior dislocation of the shoulder is common to injure the axillary nerve. Okay, anterior dislocation of the shoulder. Okay, here is the loss of the axillary nerve, absent sensation of military patch area below the shoulder. This is axillary nerve injury due to anterior dislocation shoulder. So 4 is E. 5.
4 is E. 5. A 40-year-old woman presents after a fall on an outstretched hand with pain in the upper arm and wrist drop. There is a
wrist drop means is wrist
fracture of the fracture. Wrist drop means the fracture radial nerve injury.
Radial
this
nerve,
may be
yes.
due to fracture humeral shaft. K.
Excellent. Yes, K. Fracture humeral shaft causing injury to the radial nerve with wrist drop and finger drop.
Yes, sir.
Okay. Our last slide, and it is really more important, of shoulder conditions. Shoulder conditions are also asked. Before it, I am going to clarify in 1 minute the shoulder conditions. Any patient with pain on initiation of abduction. So there is supraspinous tendinitis or rotator cuff tendinitis, okay, on initiation of abduction. Any patient with pain from angle from 60 to 120, this is impingement syndrome or painful arc syndrome, okay? Any patient of pain on angle more than 120 is an osteoarthritis. Any patient with limited mobility all over the shoulder movements, it will be adhesive capsulitis or frozen shoulder. Okay, keep it. There are 4 conditions. The first one, pain on initiation of abduction. This is supraspinous tendinitis. Pain from angle between 60 to 120. This is impingement syndrome or rotator cuff tendinitis. Pain more than 120 is an osteoarthritis. Pain all over the movement will be adhesive capsulitis or frozen shoulder syndrome. Okay, keep it, and you can now read the questions.
Yes, sir. Question number 1. A 21-year-old woman presents with a very painful shoulder, locked in adduction and internal rotation following an epileptic fit.
Okay, this is also difficult. Following epilepsy, the common to occur is posterior dislocation. Okay, is posterior dislocation. Common after epileptic fit. Once you see epileptic fit and shoulder, this is a posterior dislocation. Epileptic fit plus shoulder pain is a posterior dislocation. Okay, remember it.
Question number 2. A 55-year-old man complains of shoulder pain aggravated on abduction of the arm between 60 and 120 degrees. It is history of impingement syndrome. Of question number E.
Yes, E. Excellent. Impingement syndrome or painful arc syndrome.
Question number 3. A 30-year-old bodybuilder presents with a painful shoulder after weightlifting. Flexing his elbow reveals prominent lump in the upper arm.
This is a tricky question, came before. You should keep it all. Just a lump which has been felt after weightlifting with even stress on your biceps muscle. So the long head of biceps is ruptured and you feel the lump in the upper arm. Rupture long head of biceps. After vigorous exercise and weightlifting is the rupture long head of biceps. This is a previous question came. Please keep it. Okay, then 4.
A 50-year-old man complains of 9-month history of stiffness in the shoulder, and the shoulder was originally extremely painful, but now only stiffness is remained. This is history of adhesive capsulitis.
Yes, stiffness all over movement of the shoulder, yes. Which started initially by pain. Later on, it became painless. Usually adhesive capsulitis or frozen shoulder syndrome starts by pain due to tendinitis and the capsulitis of the joint, then later on it became painless. So 4 is key. 5.
A 65-year-old woman presents with shoulder pain and restricted movement in all directions, and X-ray shows reduced joint space and subcondylar. Reduced joint space, subcondylar, so that means it's osteoarthritis. Option D.
Okay, these are the criteria of osteoarthritis: presence of osteophyte, subcondylar sclerosis, subcondylar cyst, and reduced joint space. 4 criteria, you should keep them for part A and also for part B. 4 criteria of osteoarthritis are reduced joint space, osteophytes, subcondylar sclerosis, and subcondylar cyst. Okay, yes, excellent. I have finished the session today. Thank you all for participation. You all are great.
Thank you, sir, conducting this nice session.
Okay, thank you. Please, this recording will be in the group. You can see it. And please revise orthopedic again. All the tricks of all MRCS are here in this lecture. Okay, see you again and goodbye.